Okay, that's the wrong slide. Going backwards in the slides. Sorry, guys. Taking a minute to go backwards in the slides. Okay. So, female reproductive tract in the reproductive system, you're going to have the ovaries that are going to produce the secondary oocytes, or eventually, once it's ovulated, what becomes the eggs. And also, the ovaries produce estrogen and progesterone. The uterine tubes, also known as the uterine horns or the fallopian tubes, it's all the same thing. If you're looking at like Khan Academy or other resources, those are all the same thing. And it's primarily responsible for the transport of the unfertilized egg to the site of fertilization in the AIJ, the ampullary isthmus junction, which is part of the fallopian tube. So fertilization happens in the fallopian tube. And then the fertilized ovum then goes down to the uterus, and the uterus is where you have gestation or fetal development. The embryo will implant itself, the ball of cells will implant itself into the lining of the uterus, and then develop a yolk sac and placenta, and then develop from there. You also have the vagina and the external genitalia that constitutes the vulva. The vulva is going to be the vaginal opening, the urethral opening, and then the labia major and the labia minor. And then you have the mammary glands that produce milk. And the mammary glands are only fully going to produce milk if you are pregnant and give birth. You will release a hormone called prolactin. If you become pregnant or if you are on certain types of birth control, your mammary glands or your breasts will continue to develop. So they'll start that secondary development, but unless you actually give birth, they won't finish that secondary development. Um, and then we'll go ahead and open up all the blanks so you guys can see them. Basically, the overview of oogenesis is going to be meiosis. It's meiosis one, it's meiosis two. The kind of cool thing about eggs is that in utero, and we kind of talked about this in class, so the egg that made you was actually created in your grandmother's body when your mother was an embryo. So when your grandmother was pregnant with your mother, who was a little embryo, that egg was created. It started meiosis one. It then arrested until puberty for to finish meiosis one. Started meiosis two at time of ovulation, and then doesn't finish meiosis two until after fertilization. So, technically speaking, if a female ovulates and the egg goes unfertilized, it actually never finishes meiosis. So, it needs to be fertilized to finish meiosis two and to extrude or get rid of the last polar body. Um, Basically, most of the oocytes that you produce in utero when you're a tiny little embryo, female embryo, most of those oocytes are going to be reabsorbed. They're not going to fully develop. They're not going to finish out meiosis. They're basically you're going to start with anywhere from 200,000 to 2 million, and then at around puberty, you're going to have around 40,000. And of those 40,000, several of those are going to start maturing as follicles, but only one, sometimes two, sometimes three, but usually only one is ovulated. Whichever follicle is the largest at time of ovulation, and then that oocyte is ovulated. The rest of those follicles that had started the maturation process are now reabsorbed, and they are no more. And so really you're only going to ovulate about 400 times. So only about 400 oocytes. It can be more if you ovulate two eggs at once, three eggs at once, obviously, for multiples. And then there's a cycle, there's a phase. On average, the female cycle is 28 days, but it can range anywhere from 25 to 32 is the typical range with most female humans at 28 days. This is just a comparison chart between the female reproduction, the oogenesis, and then male reproduction, spermatogenesis, production of sperm. And just the idea that around birth, you're going to start with either the primary oocytes or the spermatogonium, which is the pre sperm. And then around puberty, they're going to start undergoing meiosis and then split. The only thing is with females, it's a 1-to-1. You start with one primary oocyte or oogonium, and then you end with one ovum, so one egg. 1 to 1. Whereas for males, they undergo the full meiosis 1, meiosis 2 after puberty in the testes. And so every couple of days, you're making new sperm. And so when you start that spermatogenesis, it's really one spermatogonium makes 4 mature sperm at the end. Okay, in the female reproductive tract in the fallopian tubes, so you can kind of see right here, these structures, they're finger-like projections. They're called the infundibulum. They're not actually attached to the ovary. So if you have the ovary kind of hanging out, they're right here, and they're not actually attached. So when the follicles start to develop, when one follicle is the largest, that's going to rupture, release the oocyte. And the infundibulum's actually doing this. They're kind of like finger-like projections, like they're trying to create a current to kind of sweep the egg inside. Sometimes you can get where the fertilized egg, fertilization usually happens right around here. Sometimes you can get where the fertilized egg comes back out and implants on the outside, or maybe it's fertilized and the egg, maybe you have overeager sperm and the egg hasn't gotten all the way down the tube to the normal side of fertilization and the flow isn't heavy enough. In the fallopian tubes, that peristaltic contractions aren't enough to move it along. And so it ends up coming out here and it can embed itself on the outside of the ovary. It can embed itself in the side of the fallopian tube if it gets too far in its mitotic development. It can embed itself on the outside of the uterus. It can embed itself on the bladder. That's called an ectopic pregnancy. And that pregnancy does have to be surgically removed. It would not result in viable offspring. You would not have a viable pregnancy. And oftentimes it can be painful and it can be life threatening because eventually it would grow too large, especially if it were like inside the fallopian tube. It can rupture the fallopian tube. Um, it can grow into the bladder, it can grow into the kidneys. Anything that is in that abdominal cavity, it can attach itself to on the outside. And that does have to be surgically removed. So it's ectopic pregnancy. And then the ciliated cells, those are going to produce nutrients, the lining for the egg, and then the sperm if they've made it all the way up here before it travels. So if it is fertilized at the AIJ, ampullary isthmus junction, it's going to travel down the rest of the fallopian tube into the uterus and it's going to embed itself into the endometrial lining, which is the blood lining in the uterus on the outside. The uterus is a big muscle. And so it's going to go from about like a flattened fist size and it's kind of sideways. Here's your bladder, here's your uterus. It sits on top of your bladder, kind of horizontally. Normally they show it like this in the pictures, but it's actually horizontal. And then basically, if you become pregnant, then it's going to grow to about the size of a basketball, a little bit larger. And so, yeah, it's stretchy. And then after birth, it goes back down. And then if you have another kid, it stretches back up and then it goes back down. So it's a big muscle. In this picture, don't think that like that's all blood. That's not all blood lining. That's a muscle. And then this is the nutrient lining, the endometrial lining. On the outside. This is the blood lining that grows throughout the month of a cycle. So you have your period, and then your period ends around day 5, 6, 7, depending on how long it is. And then you end up growing the endometrial lining till just after ovulation. So after ovulation, you're still going to continue to grow this because the uterus doesn't know yet that you're not pregnant. And so the egg is going to travel its way all the way down the fallopian tubes, all the way down, and not until about the time that it gets to the uterus your body's realized like, oh, you're not pregnant because you haven't formed what's called the corpus luteum. So we'll talk about that yet. And so your progesterone levels are super low. And so when that hormone is really low, that's when you're going to start your period or menses. I think I talked about that. Awesome. So fallopian tubes, it's the site of fertilization. Uterus is going to be the site of menstruation. The cervix right here, if fertilization does happen and the embryo does implant itself 3 to 5 days later in the uterine lining, then you will get a mucus plug develop across the cervix so that the uterus stays as a sterile environment. The vagina is highly acidic because of exposure to the outside. So, bacteria, viruses, fungus, like yeast, it's anything and everything because it's exposed to the outside. And so, it's highly acidic in order to prevent growth and to prevent germs, prevent you from getting sick. But the uterus, if you are going to grow a baby there, needs to be sterile. And so, you actually will end up with a mucus plug across the cervix. And that maintains the cleanliness of the uterus. Nothing gets in. This also, you're going to get uterine contractions, and that's going to help push baby along. And then for the cervix as well, because we will talk about STIs later, HPV is the STI that can carry and lead to, if you already have the genetic precursor for it, cervical cancer. So it is a sexually transmitted infection that can possibly lead to cervical cancer. And so that's why females, just like males, when they're older, should get prostate screening and should always do self exams for testicular cancer. Females should always go to their doctor, gynecologist, and get what's called a pap smear, which is a cervical exam. And then they also test for STIs. And what they're testing for is abnormal growths or cancer. Um, All right. Externally, you're going to have the vulva. The vulva is made of the labia major, labia minor. That's the skin flaps that are around the urethral opening and then the vaginal opening. And then you also have the anus. And then in the vaginal opening, that's going to be the passageway for birth, for menstrual flow, for intercourse. It is a smooth involuntary muscle. And it ends in the cervix. And again, highly acidic, like very bad environment for the sperm, death to sperm, basically. But that's why the sperm are also ejaculated with semen, because remember, in that semen, the prostate gland is going to produce a buffer, and the seminal vesicles are going to help produce fluid to neutralize the pH of the vagina. All right. In the mammary glands, it's a modified sweat gland. It's a milk secreting gland at the nipple. And just about like breastfeeding, the percentage of people that breastfeed, sometimes it's popular, sometimes it's not, sometimes it's personal choice. Um, there you go. Breast is best basically just because of the antibodies that are in it. We are still researching all the benefits of breast milk. We don't know. Formulas are much better than they used to be as far as like the ratio of fats to proteins. So baby will get the nutrients they need, but maybe not the antibodies that they would get while breastfeeding. So, but no pressure, because sometimes women will give birth and they don't produce enough milk, or they don't produce milk, or their nipples do not develop all the way, or like baby doesn't latch successfully. It can be painful. So there's lots of reasons why people choose not to breastfeed. So there's no like you have to. It's just really good for baby. All right, with hormone regulation, you need to know the hormones. In the hormones, you have GnRH, gonadotropin releasing hormone. That's in the hypothalamus, up in the brain. And then the GnRH stimulates the FSH and LH. Now, FSH and LH are both in males and females. So you should know what FSH and LH do in each, the male and the female. So the hypothalamus produces GnRH. GnRH then stimulates the anterior pituitary. Anterior pituitary produces FSH, follicle stimulating hormone, and LH, luteinizing hormone. In females, that's this chart right here. In females, the follicle stimulating hormone, it's going to do just like what it sounds. It's going to stimulate the growth of follicles. So it's going to be the beginning of a bunch of little follicles. You can kind of see they're going to race and see who gets to be the largest. And whoever's the largest, that one's going to rupture at ovulation. So follicle stimulating hormone stimulates the development of the follicles. Initial secretions of estrogens by growing ovarian follicles. Basically, then this is going to stimulate production of estrogens, because you want the estrogen. Your body wants the estrogen. You want to like look good and be happy and be wonderful, because you're going to ovulate, and that's the whole point of biology, right? Is to create other little yous. And so that's what the hormone is preparing you to do, is to ovulate and then hopefully find a mate and make a baby, because that's biology. That's, the study of life. And so the FSH is going to create or stimulate the growth of follicles on the ovary. And then that's going to stimulate the production of estrogen. That's that one. Luteinizing hormone is going to do a couple of things. Luteinizing hormone, you're going to have a big spike. We call it an LH surge. You're going to have a big spike about 2 days before ovulation. What the LH surge does is the LH surge, so LH causes ovulation. Ovulation, the rupturing of that follicle, is then going to cause the corpus luteum to form. And if this were like, so you have your ovary and the large follicle, let's say, is a zit, the zit pops, it releases the egg. It's literally what it looks like. It's a fluid filled follicle. The zit pops, releases the egg. That's ovulation. That then popped zit is going to form a little crater, so a scar. That crater is the corpus luteum. The corpus luteum is going to produce progesterone and estrogen, relaxin, and inhibin. It's going to do a lot of stuff. The main point of the corpus luteum is to maintain pregnancy. So the LH is going to stimulate ovulation. Ovulation then causes the formation of the corpus luteum. You want to have the structures and the hormones already in place and ready to go should there be sperm there waiting to meet the egg, because the egg is only viable, the ovum's only viable for 24 hours. So if the sperm are waiting there and they fertilize the egg, everything's ready to go. You have the progesterone levels necessary, the estrogen levels necessary. You have the relaxin, which is going to inhibit FSH because you don't need to make more follicles if you're pregnant. You don't need to have luteinizing hormone. You don't need to ovulate if you're already pregnant. You also are going to release relaxin, which is going to inhibit the uterine contractions. So it's going to keep you from having, because every month during your period, you probably on day, if you're female, day 1 or day 2, get cramps. That's contractions of your uterus moving the endometrial lining along to get rid of it. And so you normally will have uterine contractions every month. Well, you don't need to have uterine contractions if you have an embryo that's trying to implant itself in the side of your uterus. And so you release relaxin that inhibits that. So the corpus luteum basically is like, it's this looks like a zit, like a crater on your ovary. And if the egg is fertilized, it will maintain that pregnancy up until 9 weeks, when the embryo has now embedded itself into the uterine lining. It now has a yolk sac. It now is starting to develop the placental attachment to the uterus, and it will then start to produce its own progesterone and maintain itself. That's why a lot of pregnancies are lost um, at or before 9 weeks. After 9 weeks, it's the percentages go way up that the pregnancy is going to maintain itself. So for whatever reason, if something went wrong with mitosis, the cellular development, the movement, the placental attachment, if anything went wrong, there's a lot of things that can go wrong. Then that pregnancy would not maintain itself. At that time, she may not even know that she's pregnant yet. She may not at 9 weeks. You might be feeling morning sickness. You might be feeling some of the symptoms of pregnancy. You may not, and so you may, let's say it happens at like 5 weeks, at 6 weeks. You might just think you had a late period, maybe stress, because stress can cause your period to arrive later. And maybe you're really stressed, you're not sleeping, your diet's changed, you're very athletic, you've been running more. All those things can affect menstruation. So the corpus luteum is going to produce progesterone. So basically it's like LH to ovulation, ovulation to corpus luteum to progesterone. Progesterone is the hormone you need high progesterone levels to maintain pregnancy. If no sperm there, egg is not fertilized, egg will make its way down the fallopian tube and then into the uterus, and then progesterone levels will drop. Estrogen levels are already low at this time, and then you start the process all over again. Because progesterone, when it's high, is going to inhibit the GnRH. And if you inhibit GnRH, then you're not releasing FSH and LH. And so you've inhibited ovulation, and you've inhibited follicle stimulation. And so when you do that, you're not going to ovulate again, which makes sense. It's saving resources if you're already pregnant. But if you're not pregnant and that plummets, then GnRH and LH and FSH are going to be stimulated again, and you start the whole process over again on a monthly basis. All right, so this is what I mean by the zit. This is what I'm looking at. So several primordial follicles are all going to develop at the same time. They're all going to start. This is a race. Whichever one is the biggest, right around the end of your period, is going to be the one that starts to finish its development. and then it's going to be this nice fluid-filled pocket. It's going to literally rupture like a zit and release the egg. It poop pops, releases the egg. Okay, and then you form the corpus luteum, and this is what produces the progesterone. It's what produces the relaxin, the inhibin. It's what produces the follicles, or what produce a little bit of estrogen. So you're going to produce the estrogen. Get ready for ovulation. Estrogen, estrogen, estrogen. Pop low estrogen, progesterone, progesterone, no progesterone. Corpus albicans is when the corpus luteum is being reabsorbed. It's going away. You do this every month. Your ovaries do this every month. You can ovulate from either ovary. And then, so follicle stimulating hormone, FSH, causes this. Then the primary follicle, secondary ovum, and then LH surge causes rupturing. Luteinizing hormone, it causes the rupturing of the follicle. That's LH surge. And then the corpus luteum is going to be responsible for progesterone and then relaxin and inhibin that will keep the FSH and the LH levels low. So this is what it looks like when you put it all together. So here's the hypothalamus. So in the hypothalamus, GnRH is going to stimulate the anterior pituitary to create FSH and LH. FSH, follicle stimulating hormone, is going to stimulate the production of the follicles, which also makes estrogen. And then the luteinizing hormone is going to cause ovulation. When you ovulate, you also create a corpus luteum as a result of that ovulation. So the egg is released. What's left behind, that hole, that crater, is going to become the corpus luteum. Corpus luteum is responsible for producing a little bit of estrogen and mainly progesterone. And you can kind of see you have menstruation. So here's your period, day 1 to like day 4, day 5, day 6, anywhere in there. And then you are adding endometrial lining. Endometrial lining right around here is ovulation. So right around day 13, 14, 15. It can be a different day every month. It may not necessarily be consistent. It doesn't have to be. It's just whenever your hormone levels are right and whenever that follicle has finished developing. And so ovulation happens right around here. And so this, you're going to continue. Remember, the uterus doesn't know yet whether fertilization has happened. So you're going to continue to grow that uterine lining up until you reach the luteal phase, which is where you have the degradation, the beginning of the degradation of the corpus luteum. So now your progesterone levels are starting to plummet. And when your progesterone levels start to plummet and your estrogen levels start to plummet and they're already kind of low, that's when you're going to initiate menstruation. So right around here, day like 26, 27, 28, when your estrogen and your progesterones are plummeting, this may be when you stereotypically can have, not everyone gets it, but you can have what they call PMS, or premenstrual syndrome. And it's just the idea that your hormones have kind of plummeted. And so you might be irritable, you might feel a little off, a little bloated. You might just be able to like feel that menstruation is about to occur, your period's about to happen. Not everyone gets that. Okay. Again, this is the same thing all over again. It's just the idea that when you're menstruating, everything's low because your body's like, we're not going to make a baby. So why should we bother yet? And then after that's over, your estrogen levels are going to come up to prepare. You're going to get a huge, here's that LH surge. That LH surge is going to be about 2 days, day and a half, 2 days before ovulation, because this luteinizing hormone is what's responsible for the rupturing of that follicle. So it's going to take about a day, 2 days, and then you're going to rupture that follicle. The egg's going to travel. It's viable for about 24 hours. At that time, however, your estrogen levels are kind of coming down at the same time that your progesterone levels are coming up. And notice your progesterone levels really start to gain after ovulation because now you're forming that corpus luteum. So now that corpus luteum is producing a bunch of progesterone. Your estrogen level is low, but now it's coming a little bit back up because again, that corpus luteum also produces estrogen. Also produces estrogen. And then right around day like 25, 26, now your body's like, oh, egg wasn't fertilized. We're not going to grow an embryo. And so then your progesterone levels are falling, your estrogen levels are falling, your FSH low, your LH is low, everything's low. And that's going to typically be right before you start your period again. And that's going to initialize menstruation, that you need to get rid of that endometrial lining because now it's old. And then you're going to grow a new one so that it's a nice nutrient rich, oxygen rich environment for the embryo to grow should fertilization take place. That's the whole point. And so, yeah, so right around there, your progesterone diving, taking a nosedive, is what initiates your period to start all over again. If you are on the pill, normally what it does, birth control, is that it will maintain a higher level of progesterone and a lower level of estrogen to the point where it fools your body into thinking you are pregnant on the progesterone and estrogen level. So it doesn't initiate like a bunch of other changes that other hormones are responsible for, like oxytocin and prolactin and things like that. Like it doesn't initiate those, but it does maintain that progesterone and estrogen levels so that you maintain low follicle stimulating FSH and LH levels. So it goes much lower. Oh, and then I wanted to go back here just to this one real quick, because remember, all right, so comparison wise, so try to compare the notes because, especially for this, FSH, follicle stimulating hormone, is going to be responsible for spermatogenesis in males, where it's responsible for stimulation and growing of the follicles in females. It's going to be sperm formation in males. And then the luteinizing hormone in females is responsible for ovulation and the corpus luteum, which makes progesterone and estrogen. So the two hormones. Luteinizing hormone in males is going to be responsible for testosterone production. So there, I wanted to make sure like I got that comparison in there with you guys. And then this again, it's a repeat of like what's happening: the LH surge, the FSH, the follicle, the corpus luteum, your hormone levels, estrogen, progesterone, the thickness of your endometrial lining, that's the nutrient lining, the blood lining of the uterus. And again, the hypothalamus is going to stimulate the GnRH. GnRH is going to stimulate the anterior pituitary. Anterior pituitary is going to make FSH and LH. And then in males, FSH is going to be for sperm production, and in females, FSH is going to be for follicle production, follicle stimulation. And in LH in males, it's going to be for testosterone production, and LH in females is going to be for ovulation, which then will form the corpus luteum, and then the corpus luteum will then do progesterone and estrogen, and then relaxin and inhibin. So it does them both. So for females, at least, it's kind of like, the old lady that swallowed a fly kind of thing. It's like, well, the LH is responsible for the ovulation, which is responsible for the corpus luteum formation, which is responsible then for the progesterone and the estrogen. Whereas in males, it's Leydig cells and they produce testosterone. There you go. And after fertilization takes place, you kind of become a ball of cells. It's going to be instantaneous. You're going to be a fertilized zygote. So you're going to go from two haploid sperm, haploid egg, into a zygote. So you have a full complement of DNA now. The two nuclei have fused of the sperm and egg. And then you start undergoing rapid amounts of mitosis over and over and over and over and over again. And you become a morula, which is just a solid ball of cells. And then a blastocyst is where you start to fill in with fluid. So the cells start to like fold in and you start to get cavities in there. And then you're just going to keep going and going and going. So here's like the blastocyst. It's going to be an inner pocket and folding of cells. And you're just going to become more and more dense. The cells are highly unspecialized now. They're undifferentiated. And so based on their location at a specific time in development is where you will develop where they'll develop into what. So how they differentiate is basically based on location. And then in pregnancy, it's actually going to burrow into the uterine lining. And then the embryo is going to develop. It's going to have its own little yolk sac. Then it's going to develop placental attachment. How the body knows that it's pregnant is that the little embryo is going to start releasing what we call human chorionic gonadotropin, HCG. That is, it prevents the degradation of the corpus luteum, so it keeps the corpus luteum going. So the embryo is going to produce small amounts of HCG that keep the corpus luteum going, and the corpus luteum is then going to continue to produce the progesterone that keeps the FSH and the LH down. It keeps the relaxin high, so it inhibits uterine contractions. So it basically allows the embryo to have a nice place to live that isn't going to try to get rid of it every month. And so it releases the hormone that helps the corpus luteum release the hormone that maintains the pregnancy. And so at around 9 weeks is when the embryo can produce its own progesterone and maintain itself, so it no longer needs to have the corpus luteum maintaining it. And so HCG is what's tested for if you were to use a urine stick, a pregnancy test, pee on stick, 2 lines, 1 line, not pregnant, 2 lines pregnant. It's basically testing for the presence of the HCG because it is secreted, excess amounts of it is secreted in the urine. This is just the ball of cells, the little blastocyst cavity, the trophoblast, the inner mass of cells. You're going to get cells that grow along all the outside, then they're going to go on the inside, then they're going to fold, and they're going to create different types of linings, and those different linings are going to become different tissues once they differentiate. And it takes about 9 months. It's actually a little bit over 9 months because most people don't know the day that they ovulate. And so for pregnancy, most of the time they calculate your gestational length, your pregnancy length, based on the first day, the last day of your first missed period. First day of your last day of your last known period. Oh, I'm gonna get there. Last day of your last known period, because most women know when their period started, when their period ended. Like most people know that. They may not know when they ovulated exactly. So gestational length is actually a little bit over 9 months. And again, this is just implantation into the uterine lining. And it's going to grow up into the uterine lining. There is no exchange, like there is no connection of circulatory systems. I think that was a misnomer last year too that I want to kind of address. You have a placenta that has an interaction with the uterine lining of mom, and so there's lots of blood vessels in between that do an exchange of gases and nutrients and waste across in these capillaries, these blood vessels, but there's no actual like attachment in the fact that like mom's blood is not circulating through baby's blood. Um, that would make no sense because you can carry a baby who has a completely different blood type from you based on the blood type of your partner. Like if you were O negative and your partner was A positive, you could carry an A positive blood type baby. Um, so there's no exchange of blood until birth. And then here we go, STIs, yay. These aren't blank for fill in the blank. It's the idea that in chlamydia, you can be asymptomatic for years and have chlamydia. What I mean by asymptomatic is you display no outward symptoms. You may go to get STD or STI testing from your doctor. If you are sexually active, you should have that done every year. And you could get tested and pop positive for chlamydia and you didn't know it. Maybe you talk to your partner and they're like, I don't know what you're talking about. And then they get tested and they have it. Okay. So it's blank for a reason. It's most of the time you can be female and be asymptomatic for chlamydia. You can also be male and be asymptomatic for chlamydia. Treatment is antibiotics. It's actually very easily treatable. Gonorrhea is now easily treatable with antibiotics, but it didn't used to be as easily treatable, so it's not too bad. You can also be asymptomatic with gonorrhea. Gonorrhea is dangerous if you do get pregnant and you have gonorrhea. It can cause blindness in the baby, and so they normally will treat that with antibiotics. Syphilis, you can go insane. That is the one that's like, people can go insane if untreated syphilis. You're pretty far gone if you're untreated syphilis. You will have outward appearance. Usually syphilis, you're going to get canker sores, and it can move to other organs. On the inside, you can have internal sores. You can have external sores. You can, yeah, it's not pretty, but treatable. Treatable. So syphilis again, treatable with antibiotics. Herpes is the gift that keeps on giving. There is no cure. There are medications that will suppress your outbreaks, but it does not cure it, and it does not prevent all outbreaks. It's not 100% effective. So you can still end up with outbreaks. It is a viral infection. It lives in your cells. It is related. So genital herpes is, I don't remember which simplex, but it's, just for example, it'd be like herpes simplex 1, and then oral herpes is herpes simplex 2. So they're related to each other, but it's not the same. And so like if you get canker sores, on the outside, like a cold sore, not a canker sore, like a cold sore on the outside of your mouth, that's oral herpes. It's different from genital herpes, but they're related. But with herpes, there's painful blisters. The virus can go dormant, it can emerge at any time. What makes herpes so not necessarily dangerous, but I mean it is. Nobody wants herpes, and herpes will cause can cause infertility issues. It can cause other secondary issues. It's just painful. I mean, nobody wants painful blisters on their genitalia. Nobody wants that, but it is not preventable through a use of a condom. Um, Condoms do not protect against herpes. And so, really, herpes is one of those where if you are sexually active, you need to be having conversations with your partner about, whoever your partner is, about STIs and testing. And are they being tested? Are they tested? Are you being tested? How many partners do they have? Like, are you in a monogamous relationship? Are you not? And those are just things that will help prevent herpes. Because once you have it, you will have it forever, and you will deal with it for the rest of your life. And that's not something that you want. And again, with a lot of the viral ones, so AIDS, again, it the same thing. It's having those conversations. Condoms do protect against HIV. They do protect against AIDS. Um, but again, it's having those conversations and getting tested. Hepatitis B, you should, if you've gone on international travel, all have your Hep B vaccine. It can cause jaundice, it can cause cancer, it can cause an enlarged liver, it can be sexually transmitted, um, it can be life threatening. HPV, human papillomavirus, that's one of those that it's viral, and the virus can, in its plasmid, contain mutations that can cause cervical cancer in women, in females. But males should also get HPV vaccine because there's a vaccine available for it, because it also causes genital warts. Nobody wants genital warts, which they're treatable, but freezing with liquid nitrogen and chemical burning, if you've ever had a wart removed, like, just nobody wants genital warts. So, my whole spiel here is your greatest protection is your brain, and using common sense, and talking and having a relationship with your doctor, that you can talk about these things, that you can get testing done, that you're getting regular pap smear, that you're getting regular physicals. That really, honestly, is your best protection. And then from there, having those conversations with your doctor about, um, if I am sexually active, what kind of protection is best. And it really is, it's very dangerous to, if you are going to choose to be sexually active but you don't feel comfortable having conversations with your doctor. That can be very dangerous. um, and so it's just be aware you need to have those conversations, because these things are out there. um, and a lot of times, like with chlamydia, you don't know uh, until you actually have it, and then you have to be treated for it, and then issues arise, and you don't want that. So use your brain. Talk to your doctor, talk to your health professional. Always go for testing. Always go for physicals anyway, because whether or not you're sexually active, even if you aren't, you should still always have a pap smear for women's health, and um, physical exam like testicle. You can do self exam if you know what you're looking for testicular cancer. So those things are out there, and you should always, if you have access to medical care, go to your doctor. There you go, guys. That is it. Quiz on Wednesday. It's only 10 points, so it can be dropped. It's multiple choice. I would advise, please come in person. because it will not take the whole period. And the rest of the period on Wednesday, we are going over lab preparation for the gel electrophoresis lab that we're going to do on Friday. And so you're going to need practice with the micro pipetters, so that you know what you're doing. You don't suck up a bunch of stuff into my pipetters. So we're going to do practice on Wednesday. So it's going to be quiz at the beginning of the period, and it's going to be 10. We're aiming for like 10, 15 minutes. It's all multiple choice. And then it's going to be pipette practice for the lab, and then prepping and reading for the lab. So that's class on Wednesday. Awesome.